You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Hello and welcome back to another Citations Classics here with the trauma folks, the trauma dogs. You got myself, Matt, and then we got Brie and Nick with us again today. Say hey, guys.
Hey, guys.
Hey, everyone.
Yeah. We're firing. We're back from we're in the new year now. It's still very cold. It's actually snowing outside. It was like getting warmer and then got a lot colder. But we're, the cold weather's just even more time to dive into the literature and talk about these great citation classics. So you're lucky. We're here. We're going to be talking about. We're moving on to the hip fractures from the pelvis and acetabulum that we've been talking about the past couple of weeks. And we're going to be talking about hip fractures in general today, kind of counseling patients. What are important papers that go into counseling patients or help inform how we counsel patients? And so you can see if you look at the slides, we have hip fractures. The quote is, "When will I be able to go home, doctor? I'll be just fine, right?" And I think we'll unpack that a little bit, and we'll talk a little bit more about what they might be able to expect. So before we go into it, I want to present a patient little scenario for everyone that we'll be kind of using to frame our narrative today. And so Nick and Brie, we were talking about a little bit earlier. So we've got a sweet grandma lives at home by herself. She's able to shop for herself. She goes out to the community ambulator. She uses a cane, but gets around, does everything for herself really well. And last night she was having a good time. She started drinking a bottle of wine. She was going back to the kitchen to rinse her cup when she tripped over her cat, landed on her hip, and she comes into the emergency department. The whole family's there, including the cat. Somehow they snuck it in. Everyone's there. The cat even looks concerned. Everyone's gathered around grandma. You walk in to see the consult, and you walk in, and the whole family's like, "Is she going to die? When is she going to die? Is she going home? We'd love her to make it go home. How do we make her better? We hate surgery. Can we just wait for it to heal?" And you're just hit by a bombardment of all these different questions. You take a step back, and you want to make sure that you're counseling them really well. You want to make sure that you're using science and data to really make sure that we're making the best decisions for their loving grandma, so that cat has someone to come home and take care of it again. And so that's what we're going to be covering today, kind of what goes into what your spiel can be when talking with a hip fracture patient, when discussing a hip fracture patient, and then the things to consider when we're planning on when and how to do surgery. We'll be unpacking this more kind of surgical strategies a little bit more as we go into hip fracture specifically later episodes. So first off, I'm sorry to keep hitting you guys with all these disclaimers. I know last time we were talking about pelvises, I was talking about, hey, I'm a third year resident, so definitely still learning the mysteries of the human pelvis. But full disclaimer is I'm more confident in the mysteries of the human pelvis than I am necessarily in unpacking statistical analyzation. I don't have a strong statistics background. I very much during journal clubs, I'm listening very intently to the folks that are much smarter than me, talking about the different ways to analyze data and the different confounders and all that. And so I'm definitely very much learning all of this as well. I really rely on editors as well as different organizations that kind of unpack some of this. And so when we were identifying papers that we wanted to talk about today, one, we want to make sure that they're highly cited, because as these are citation classics. But then also the Orthopaedic Trauma Association that we talked about has an evidence-based medicine section on their website that we really use to identify some of these great papers, and can really try to trust that. And then you also want to make sure you're not just blindly trusting. We take a look and make sure, do these conclusions that are being made, do they make sense? Does the thing that we're investigating makes sense, and this is just providing us a little bit of extra information or strong data to support what makes sense, and just giving us a little bit of a stronger recommendation. I just also want to say, if you see important aspects of these papers that should be considered, please let us know in the comments or shoot us an email. Those of you who are listening that have a stronger background in this, would take a look, dive into this, and let us know. But overall, we're looking at some well-powered reviews that have been completed looking at hip fractures that have really moved the needle as far as timeline when we try to get to these fractures. They're important to remember when we counsel our patients' recovery. It's always good to understand where some of the numbers that we quote to our patients come from, and that's kind of what we're going to be looking at today. All right, so with that, let's go ahead and move forward. And we got a background. Brie, real quick, what is a hip fracture? Like what bones are we talking about here?
Yeah. So when we're talking about to the patient about this type of injury, it's important that they actually understand what's going on. So really simplifying it down to the hip joint is a ball and socket joint. So telling them, think about the big bone in your thigh, the femur. So it's the ball of that. And that's forming a joint with the part of our pelvis called the acetabulum. And that's really what our ball and socket joint is. And
Perfect.
then,
It's like, yeah. No, sorry. Go ahead.
And then it just talking about the fracture type, which I think Nick was going to go into.
Yeah, exactly. Yeah. So Nick and Brie nailed it, right? A hip, you got to break it down for our patients. It's the ball and socket joint. We're talking about the ball side of that joint. It's not an acetabular fracture, which would be the socket. It's the ball side, that proximal femur, the top part of that long bone. And so yeah, Nick. So when we're talking about, like, as orthopedists, when we're thinking about hip fractures, what kind of is included in hip fracture? What's in that basket?
Right. So a lot of times when we say hip fractures, we're going to talk about the femoral neck, so our subcapital or transcervical and basicervical femoral neck fractures. We also refer to hip fractures a lot of times as intertrochanteric fractures, the area between the greater trochanter and the lesser trochanter.
For sure. Yeah. Perfect. Nailed it. Yeah. See what I did there? Nailed it. So yeah, and we'll talk about specifics of treatment of kind of each of those individual things later. But we're talking about the big basket of hip fractures, those femoral neck fractures and the different subtypes which you talked about, as well as the intertrochanteric fractures. And we'll talk about, standard ubiquity, reverse ubiquity at a later time, later episode. That's another show. And just important to highlight that, like, subtroch fractures, those kind of things, we're not talking about those. Those are more kind of a different beast. So we're talking about those femoral neck fractures and intertrochanteric fractures. And just like any surgery, and particularly in this surgery, which we'll see, is our goal is to restore function, to improve pain, and prevent complications. And this is primarily achieved by early mobilization, getting people moving. And you'll see, we'll talk a little bit more about that as we go. So let's keep it a go. We're going to be zipping through a couple of these early ones. You guys are going to hear me talk a lot at the beginning, and then we'll be kicking it over to Brie and Nick. So our first paper is 2019 paper out of the Journal of Orthopedic Trauma, talking about non-operative geriatric hip fracture treatment is associated with increased mortality, a matched cohort study. And at first glance, you look at this and you're like, well, duh. But it is important to look at these things to really define some of the frequencies, to know more about what the trends are, and when we're talking with our patients, and to really, you got to prove some of the basic stuff as well, and really talk about the basic stuff to have a true understanding of the rates of these things. So this is a retrospective cohort study. They did a matched cohort, a matched operative cohort to a non-operative cohort. Important to always talk about what that means. And so a non-operative cohort, they used oral medications and cryotherapy for pain medication. And how people were selected for non-operative cohort, right? So it's as a retrospective. And so these patients were only treated non-operatively when it was requested by the patient or the family. This was done in consultation with a palliative care team, as well as the internal medicine team, in order to talk about, hey, do you understand the implications of non-operative treatment, which we'll go into what those are. But we even knew that in 2019, we already had an idea of what non-operative treatment was, but they wanted to make sure that they talked about this. And then so that's always going to be a little bit of a tricky thing to try to match for, is these patients are choosing these you have that selection bias. Well, they did a matched operative cohort, and the operative treatment could be anything from arthroplasty to cannulated screws to a sliding hip screw or a cephalmedullary nail, right? Things that we use to treat those femoral neck fractures and intertrochanteric fractures. Some interesting points about this is most of the femoral neck fractures were treated with arthroplasty, specifically hemiarthroplasty. And most of the intertrochanterics were treated with a sliding hip screw rather than a cephalmedullary nail. That's up to 86% of those intertrochanteric fractures were treated with sliding hip screw, and we'll go into like why that's interesting in a later episode. But it's just important to kind of to keep in mind, lots of different fracture patterns and lots of different interventions treated to treat this. So they matched the operative cohort to a non-operative cohort. The non-operative cohort or the people that we're looking at are geriatric patients, 65 years of age or older, with a femoral neck fracture or an intertrunk fracture that went operative or non-operative treatment. The main outcome that they were looking at was mortality. And they looked at that in-hospital mortality, 30-day mortality, and 1-year mortality. So ultimately, they looked at all femur fractures between 2004 and 2012. There was over 1,000 patients, over 1,036 were operative and 77 were non-operative. They looked at all possible confounders and tried to match for that. And these were risk factors that have previously been associated with mortality in hip fractures. And so these are important things to know just in general as orthopedists, right? Risk factors associated with mortality in hip fractures: age, sex, fracture location, the Charleston Comorbidity Index, basically looking at the number of different comorbidities, pre-injury living location, dementia, and cardiac arrhythmia. Ultimately, they're doing a matched cohort, so they had 77 non-operative. They did 2-to-1 matching, and they did matching without replacement, and that resulted in a total of 154 operative patients and 77 non-operative patients. And you can see we have one of the tables up, just talking about the patient selection in the entire cohort, the non-operative and the operative, kind of the breakdowns of that. And basically, it shows that there's no significant difference between our operative and non-operative cohorts. So we feel pretty good about the matching that was done. I pulled up here just for those of you who really like statistics or know a lot more about statistics. They did a Kaplan-Meier survival analysis for mean and median life expectancy. They did Shapiro-Wilk test for distribution of continuous variables. They did student t-test for parametric data, which is data that falls in a normal distribution of a bell curve. They also did the Mann-Whitney test for non-parametric data, which is the data that's not in a normal bell curve distribution. Chi-squared test, which looked at the differences in data, as well as the log rank test to look at the differences in curves. So they did a lot of statistical analysis on this stuff. And as you'd expect on our results, the mortality is a lot higher in the non-operative group than the operative group at all of our time points. In our in-hospital, we have non-operative mortality of 30%, operative 3.9. 30-day, 63% non-operative, 11% in operative. So basically, it boils down to, at a year, 84% of non-operative patients, an 84% mortality rate, where in the operative, a 36% mortality rate. The one interesting thing is that the length of stay, or the hospital length of stay, was lower in the non-operative group than the operative group. That might be a little bit different, but if you think about they had one outlier in the operative group that stayed for 146 days, that pushed the length of stay average up by an entire day. And then also, a lot of times, if they weren't having the discharge planning immediately on presentation in the operative group, it only started after the operative intervention, and so that kind of creates a little bit of lag time. But mortality is certainly higher in the non-operative group, and significantly higher, like significantly higher. So what's the conclusion? We have a 1-year mortality rate of 86% in the non-operative group. However, I like to highlight from this that we get some good data. Even with the operative treatment, there was 36% mortality. Not just something that's a fracture that we take in isolation. It kind of be as an indication of overlying status of the patient. Important to note, this 36% mortality at 1 year, this was a matched cohort of people who underwent non-operative treatment that are pretty unhealthy or kind of at the end of life. And so they actually did find that the Charleston Comorbidity Index was lower in their unmatched patients or their healthier patients. And so we could expect that maybe the mortality rate at 1 year for operative treatment overall as a group is a little bit less than that. I think an important limitation of the study is, once again, that's that self-selection of patients to non-op. They did look at pre-injury ambulation. They had no difference in the mortality rate. To highlight again, the non-operative management did not mean a longer stay. but the operative treatment was better for mortality at all time points. And so it's an important discussion to be had with patients. So based with this, Brie, so based on this, we have our patient, she came in, the cat's there, the cat's meowing, running around, but the family's like, hey, if we could, we don't like surgery, but we want to get her back moving around and back living at home. Can we do non-operative treatment? What would you tell these folks?
So essentially what I want to discuss with this family is that what we do when we care for a patient is we have an entire team of people working together to essentially look at whatever their medical comorbidities are and their mobility is at baseline, in addition to thinking about what type of fracture the patient has. And what we do is essentially help the patient get back to their baseline through the use of the internal medicine team, physical therapy, and the orthopedic team in order to figure out what interventions that patient really needs in order to really reduce their pain and, like you said before, increase their function and get them back to a point where they're happy and healthy. And the patient scenario you had, she was living alone. So if that's her goal, to get back to that baseline, it's really important that we optimize her outcomes by bringing her into surgery and thinking about what her medical history is in order to figure out what the correct timing would be for that. But really, we want to have the patient be an active participant within that team in order to figure out what is best for them.
Yeah, for sure. And you brought up a lot of really good stuff that we're going to be diving into over the course of this. But yeah, like it's really, it comes down to, if you want a chance at getting back we got to be talking about surgery. Like these are folks that if you don't get surgery, you're not moving around, you're not going to do well. And we can talk about the reasons why non-operative treatment doesn't do better, but people aren't able to get up and mobilize. And if you're not able to mobilize, life's about momentum. If we're not able to get up and move around, our body starts kind of failing us a little bit more. And these people are coming in with comorbidities. There's a reason why they fell. There's a reason why they fractured. And so if we give those other reasons a head start or a boost by not moving around the patient, and all of a sudden they're starting to get ulcers, they're starting to get pneumonia, they're starting to get other different things because they're not moving around, that's certainly going to hasten the end of life. And so this is already kind of part of the end of life process, but if we want to try to stave that off and get them back as much as possible, we got to be talking about surgery. Okay, good. Let's blitz through another one real quick. We've got the impact of a co-managed geriatric fracture center on short-term hip fracture outcomes. And this is in the Archives of Internal Medicine in October 2009. Bet you didn't hear that. Think we were going to be talking about internal medicine papers in here, but it's important to know what our colleagues are talking about, and if they ever want to not admit a patient, be able to use their data to help our cause. But this is really going to be talking about, like Brie was talking about, that the importance of that co-management team and the whole team, including the patient, moving forward. But we'll take a look exactly what this paper talks about. It's October 2009, Archives of Internal Medicine. So the background, kind of, we're talking about patients with hip fractures have comorbid conditions. And in order to address that, this center, this is termed a geriatric fracture care center. They evolved a treatment approach that assumed a couple different things, and they built a team around that. One, they assumed that most patients benefit from surgery. Yep, we talked about that last time. Shorter time to surgery is less time to develop iatrogenic illnesses. We'll talk about that in future papers here coming up, but yes, agree with that. Co-management with frequent communication avoids iatrogenic problems. That's a big one. So that's what we're going to talk about here, is kind of really examining that and see if that bears out in some data, that co-management with frequent communication avoids iatrogenic problems. Standardized protocols decrease adverse outcomes. That's kind of held true across many different platforms, from the military to medicine, so that makes sense. And then discharge planning begins at admission. That makes sense. That can definitely decrease our length of stay, get people out a little bit sooner, find a better place for them. So they were comparing between two hospitals, and we'll go into a little bit more, but the Geriatric Fracture Care Center focused on those 5 things that we talked about. They had subspecialty consultations were minimized, and they're being managed by a geriatrician as well as an orthopedist. It's based in a 261-bed community-based teaching hospital that has actually a close affiliation with local assisted living facilities and nursing homes. And so they get a lot of geriatric hip fractures. This was all compared to a usual care hospital, which was a tertiary care hospital, kind of what you think of as an academic center. Overall, the 2 hospitals shared house staff as well as medical students and faculty. They have a similar catchment area. They're very near each other, one being a tertiary center and one more of a smaller community-based hospital. And an important thing to notice to talk about is they didn't have any overlap in staff, but the staff belongs to the same department, so overall treatment trends very similar, but they were not operating at both hospitals. They had different staff operating there. So the study design is a retrospective cohort study. It was done from 2005 to 2006. They looked at the Charleston Comorbidity Index in order to kind of help control for some of these things. They looked at dementia. In their analysis, it was identified as a difference between the sites, and so it was included as a covariate in order to prevent that from causing undue skewing of the data. And once again, it was done at 2 separate institutions. They looked at a couple different outcomes. One is time to surgery. 2 is complications, which they define the complication-specific parameters in the paper if you want to take a look. They looked at restraint use, length of stay, mortality, and readmission within 30 days. They analyzed this all with chi-square test, Fisher test, unpaired t-test, linear and logistic regressions in order to take a look at everything. So overall, the population, they had included folks with 60 years old or and older with proximal femur fracture, which we talked about the fracture patterns before. Then they had 193 at the Geriatric Fracture Center and 121 at the local institution without the program at the tertiary care center. And I put the characteristics of patients at baseline, which is really interesting. If you take a look at the Geriatric Fracture Care Center, the age is significantly higher. Those who are community dwelling or more independent ambulators is lower. So, there were more people at assisted living facilities and nursing homes that went to the Geriatric Fracture Care Center. The Charleston Comorbidity Score was on average higher at the Geriatric Fracture Center, and the dementia percentage was higher once again. And so, taking a look at this, you'd suspect that the Geriatric Fracture Care Center has a little bit of an uphill battle to do here in order to really take care of their patients. So then we look at the results. And so looking at the results, the outcome, we see that at the Geriatric Fracture Care Center, the time to surgery was significantly less in hours, 24 hours as compared to 37. The restraint use was lower. Length of stay was lower. Complications overall was lower, 30% as compared to 46%. And that was all of those things are significant. There's significantly less delirium, so significantly less postoperative infection, which includes urinary tract infection, pneumonia, and surgical site infection kind of lumped together, and then significantly less cardiac or hypoxia complications. And so even with that kind of uphill battle, the Fracture Care Center with this team-based model performed better. And so that's pretty strong. We see, in conclusion, the patients got to surgery faster, they had less complications, they had a shorter length of stay. And I put an important note is it's not just including a geriatrician and an orthopedist together. This is also, they had standardized order sets, includes nursing staff that was familiar with taking care of elderly patients, physical therapy team that is used to doing hip fracture recovery. So it's a reflective of a total approach to patient care. And you don't just add in an internal medicine consult or asking internal medicine to be primary. This is a whole process that was instituted, and it's really important for the total to care. And you can see it makes a big difference. And so taking a look at that, Nick, I kind of rambled on a little bit there talking about all this, but when talking with the patient now, when you're talking with the patient and family, you're talking about who's going to be taking care of them and what the post-operative course might be like. What might this kind of bring up, or you want to make sure you bring up and talk about?
Right. So we definitely want to include that, hey, we're going to have a whole team of people, physical therapy, like you said, nursing staff. And the more people we have on board, there's evidence that'll demonstrate the the better our outcomes could potentially be. Like you said, faster surgery, shorter length of stay. They'll probably be transferred to like the orthopedic floor if the hospital has that sort of capacity, where people, the staff is used to taking care of these kinds of fractures, and they'll likely get better care there, and they're likely going to have a holistic team that will be participating in the entire care of the patient and their comorbidities.
Nice. Yeah, perfect. Like we just highlight, hey, it's important that we take a whole look at all of you and make sure that we're helping you as much as we can, taking into account all the things that make you you, including your medical history and your home situation and your strength and ability. And so we want a whole team to be able to look at all those things to help optimize all of those things and work with you. And the most important part of this is you, right? Is you're being able to work with physical therapy, you working with all these different teams to make sure that we're considering everything. But yeah, really highlight like, hey, we're going to have a lot of people working with you. We're all talking with each other. We're all working with you. And it's all to make sure we're doing the right thing at the right time. But yeah, so in surprise, when you think about all those things and you really put together a team that's going to help support a patient, that we see better outcomes, and that's fantastic. And makes me kind of curious if maybe we could do some of these things about some of our other subspecialties. I think, actually in the joints literature, right, a standardized approach to our joints patients has improved our ability to get people moving and everything again. And so it is something that we see across the board, but particularly in hip fractures, where it's really important because we're talking about a risk for mortality, right? Like that's the ultimate big endpoint. All right. So kind of getting into now talking about timing of surgery, and we'll have two papers that talk about this. And we're going to start off with a 2010 paper at the Canadian Medical Association Journal, 2010, The Effect of Early Surgery After Hip Fracture on Mortality and Complications, Systematic Review and Meta-Analysis. And this is a big paper that was very rigorously done. They really took their time, and they had pretty strict inclusion criteria. They had studies with 60 patients who were 60 years or older. They had a low energy hip fracture. They had evaluation of, they had a discussion of preoperative surgical delay. They looked at all cause mortality. I think a big thing here is they looked at everything that was in a prospective design. They did not look at any retrospective studies. They also looked at no language restriction in order to help increase the strength and the patient encatchment for that. And the main outcome measurements, always really important to identify what were the papers looking at, and they looked at mortality. And so taking a look at their population, they identified almost 2,000 papers. They excluded a ton based on, like letters, case reports, all that. I think when we're doing these meta-analysis, it's easy to kind of skip over that flow chart that talks about articles identified by initial search to get down to the ones that are included in the systematic review. But it is important to take a look at what they were looking at, how they decided not to look at different things, because that's what they might be missing out on some different things, or they might be not taking some things into account. But they did studies on Medline and Embase in order to find all of these. They physically went through the archives of the OTA, COA, MAOA, AAOS, ABJS, the Piedmont Society, go Duke, and to make sure that they weren't missing any unpublished data. They contacted all these people. They did a huge amount of work in order to make sure that they were in catching all of the appropriate information and studies. And so when they looked at that, they also then looked at the quality. They used an adapted version of the Newcastle-Ottawa scale for cohort studies. Basically, it assesses for a selection and attrition bias. The grades are based on selection and applicability of the study groups. And they looked at if the ascertainment of the exposure or the outcome was biased, as well as the adequacy of follow-up. The Newcastle-Ottawa scale also looks at outcome, if the outcome is to make sure that the outcome's not demonstrated at the beginning of the study, which they discarded for the study because right, the outcome's death. And so obviously it's not demonstrated at the beginning of the study. So this resulted in a score from 0 to 8. They looked at papers that scored a 7 or higher as high quality, 5 to 6 score as a moderate quality, and anything less than 4 was low quality. And they also did a kappa statistic to confirm agreement when looking at these studies as far as what their score was, and it was set at 0.65. So taking a look at it, they did a primary meta-analysis, which studies that were adjusted for potentially confounding variables were included. They did a secondary meta-analysis, which they looked at studies with unadjusted estimation of mortality. It was basically a long way to talk about, they looked at relative risk. They took all of these different studies, and if they had, if they reported frequency data, they converted it to relative risk. If they had odds ratios or hazard ratios, they converted it to relative risk. They looked at relative risk at 30 days, 6 months, and 1 year. They pulled out outcome measures. They did funnel plots for publication bias. They did I-squared for heterogeneity quantification, stratified analyses, statistical tests for interactions. They controlled for inflation of type 1 error with p less than 0.01. They did a ton of very rigorous statistical methods. I talked to someone who in my program who has a little bit more statistical background than I did, and they were impressed with the rigor that they did with this. And I think this is why it's included as a strong thing for in the OTA EBM database, why we can really trust this study. They were able to identify 4 high-quality studies, 5 moderate studies, and 7 low-quality studies. And I have the 2 forest plots up here taking a look at mortality and looking at complication. And so here looking at early surgery versus delayed surgery, they have on the left all the different studies, and some studies use 24 hours. The most of them use 24 hours. Some studies use 48 hours, and one study actually uses 72 hours as the cutoff for early versus delayed. And that can definitely lead to a little bit of confounding or difficulty in interpreting these results. But what we can see on these forest plots is there's certainly a trend towards improved mortality at 30 days, 3 months, 6 months. But there is a statistically significant improvement in mortality at 1 year for operative treatment, early surgery versus delayed surgery. And so I just wanted to say that again to highlight. At 1 year, we see a statistical improvement in favoring early surgery as compared to delayed surgery in mortality. So now we just got to define a little bit more of what early surgery is. And primarily, most of these surgeries talk about 24 hours, but also some use 48 and some use 72. So a little bit of gray area there, but early surgery better than delayed surgery in mortality benefit at 1 year, with a trend towards that at 3 months, 6 months, and 30 days. Then we take a look at complication, and by complication we see they looked at pneumonia, pressure sores, DVTs, and pulmonary embolism. We see statistically significant early surgery improves or reduces pneumonia and reduces pressure sores, but not statistically addressing deep vein thrombosis or pulmonary embolisms. Basically, pneumonia and pressure sores are helped by early surgery. So to break that down, I know it was a lot of talking about statistics, which is really hard over a podcast or listening. But we have early surgical treatment is associated with significant reduction in mortality. Boom, that's our big plan, or our big overwhelming statement. But we know that 24 hours, 48 hours, and 72-hour time points were all used in the literature, and so that's like, but what is early surgical treatment? So a little bit of work left to be done. We say that the reduced risk of pneumonia and pressure sores. I think highlights of this study, it's a prospective meta-analysis. That's pretty excellent, but it's still limited as it's an observational study, and confounding is a definite consideration. But I think overall a really powerful tool when we're talking about early surgical treatment. Rather than go ahead and ask some questions again right now, I think let's go ahead and dive into Brie's study, where we talked about, we've been talking about, okay, what is early surgical treatment, 24, 48, 72, and I think Brie can shed some light on that.
Hey guys, so continuing off on that, so what is early surgery? So Dr. Pincus and his colleagues tried to address this in their 2017 article published in JAMA. So they were essentially looking at the association between wait time, so what is that ideal time for surgery, and 30-day mortality rates in adults undergoing hip surgery. So when we're talking about hip fracture surgery in adults, there's really been a variable time to surgery policy and recommendation based on whatever country of origin the surgeon is in. So for example, in the US and Canada, the guidelines recommended within 48 hours of presentation. But conversely, in the UK, that recommendation was actually within 36 hours of presentation. So there's really been kind of a lack of empiric evidence for that time to surgery threshold. And that's what these authors were trying to address and figuring out what is that time to surgery threshold before the risk of complications increases. So for their study design, they used a population-based cohort study in Ontario, Canada, and they used their health administrative databases within 72 hospitals within Ontario, Canada, to essentially find residents that were over the age of 45 who were undergoing hip fracture surgery within a 5-year period from April 1st, 2009 to March 31st, 2014. And they had a lot of different exclusion criteria, but just kind of a summary of them were if the patient had a history of hip fracture surgery before, if they incurred a hip fracture during their hospitalization, if there was significant surgical delay over 10 days, or if their surgery was performed by a non-orthopedic surgeon or at a facility with a low volume of hip fracture fixation. But their primary outcome for this study was really looking at that 30-day mortality to establish an appropriate wait time for surgery using kind of a continuous time frame in hours from their initial arrival at the emergency department until their surgery. And then they also looked at secondary outcomes at 90 days and 1 year for mortality and medical complications. And they were specifically looking at VTE, MI, and pneumonia using those time periods. So overall, they were able to identify about 42,000 patients who met the inclusion criteria. And these patients had about a mean age of 80 years old, with 70% being women. And they looked at maximum area under the curve to identify the threshold for early versus delayed hip fracture surgery. And they used 24 hours as that threshold. And an interesting thing, before they underwent the process of matching, they found that about 34% of the patients underwent early surgery, whereas 66% underwent delayed surgery. And most of these patients were actually more likely to be men with higher medical comorbidities, and they were treated at high volume centers after transfer from another healthcare institution. But after they performed matching, each group contained about 14,000 patients.
Cool. Sorry, I just want to jump in there. And that kind of makes sense, right? If you're calculating how long it takes to get to someone for a surgery, if they're coming from another institution, they've seen it in an emergency department, they're like, it's obviously going to be from their initial presentation until you get to them, it's going to be a little bit delayed. And so that kind of makes sense, a lot of those different things. And it's nice to see when these people who are matched or the people that are falling outside, when that makes sense and kind of goes along with what you expect, that's always like a really reassuring thing that we're looking at the right things and looking at them the right way. Sorry to interrupt. We'll keep going.
No, you're good. That's exactly. So when they looked at the results, they put together this chart that you're able to see if you're following along with the slides, which is essentially just looking at the hours from arrival from the hospital to surgery in comparison to 30-day mortality. And with their mean time to surgery of about 28.8 hours, they found that there's really an inflection point at about 24 hours, where after that point, the risk of 30-day mortality really starts to increase. So that's the majority of what they found with these results.
Nice.
And then
yeah.
Looking at the nice table that they've included in this study, they found that in terms of secondary outcomes, there's an absolute risk difference at 90 days and 365 days for mortality, pulmonary embolism, heart attack, and pneumonia. Those were all statistically significant, but the thing that was interesting was the thing that was not significant at all three timeframes of 30 days, 90 days, and 1 year from surgery was deep vein thrombosis. So that was what they found was most interesting, and that lack of significance for DVT in comparison to pulmonary embolism may just be due to kind of misclassification from fat emboli, since pulmonary emboli are a little bit hard to differentiate in that case. So really, they just need some future research to delineate that better. All right. So overall, in conclusion, what they found was that using a large kind of diverse and generalizable population, they were able to assess that time to surgery measured continuously in hours is a 24-hour threshold prior to that increase in 30-day mortality and the other complications that we talked about. So really what they found that's needed in the future is to provide an opportunity for quality improvement, as about 2/3 of the study population underwent delayed surgery. So really just trying to optimize patient outcomes by initiating surgery earlier.
Nice. Yeah. Wow. So that, I mean, it's a huge study. You did such a good job on breaking that down and really narrowed in on the time to surgery threshold. That's so important and striking. And I think what you highlighted there at the end is super important too, is, even the thresholds that we were using before, the 48 hours or the 36 hours, people or institutions have had a hard time meeting that. And so this is something that we need to continue to strive for and try to improve. But I'm going to actually click back a little bit to that graph that you had pulled up. What's so cool about this study, or what I thought was cool or interesting about the study, is it does show us that kind of as it moves through, as the time points move through from 0 to 120 hours from arrival to surgery, what the 30-day mortality rate is. And we have that up here. And then in the study, they have it for 30 days. They have it for 90 days. They have it for 365 days. And so it's really cool to kind of see this trend carry out across 30, 90, 1 year, carries across also the complication rates. And so it becomes pretty convincing by continuing to look at all this different stuff, and it's really cool to see that consistency. And it's really I don't know, I'm a visual learner, so being able to see these graphs and that kind of smooth increase in pattern is something that is really striking. And so definitely encourage you to pull up this study and take a look at those graphs and see how it's conserved across all the different mortality at 30, 90, 1 year, as well as all the complications. So taking a look at this and knowing our limitations as a system, when talking to the patient, Brie, when you're talking with the family, you've convinced them already, okay, we want to go to surgery because we want to get her back moving. We're excited that we have a multidisciplinary team that's involved to really help maximize and work with grandma before and after surgery. What are you going to tell them about? Okay, so Doc, when are we going to surgery?
Yeah, so we want to go to surgery as soon as it's safe for both the patient from their medical standpoint, as well as all of the different factors that are required in order to perform the surgery. So really, ideally, what we would tell the patient is that we would want to get to surgery within 24 to 48 hours, not just telling them that 24-hour set point just in case we don't quite meet that. We want to ensure that we're not putting any undue stress on the patient. So just giving them that time frame of 24 to 48 hours that we'd like to get to surgery, but we want to ensure that the multidisciplinary team is in agreement that it's the right time for the patient to go to surgery in order to kind of optimize those medical and orthopedic issues that we're trying to help with.
That's right. You want to highlight, the realities of the situation is we want to get you exactly like you said. We want to get there as soon as it's safe, right? We want to make sure that you're cleared and medically optimized. We want to make sure that the team is ready, the OR is ready. We don't want to rush into a poorly performed surgery, for a lack of a better term, or we want to be ready. We want to be ready to go. We want to have the team ready to go. We want the patient ready to go. And as you said, it's nice to give them a range. We don't want, you never can really promise anything because you don't know what's going to happen. You want to make sure that the patient is tracking along with what we're trying to do. And you had mentioned it before when we were talking, is the importance of being an advocate for our patients, right? You'll see as a resident, all of us will see as a resident, and then as attendings, sometimes there's things that hold us back from patient care that are more administrative. And as much as we can, being advocates in cases like this, where we were trying to push for this 24-hour time point, talking with our internal medicine colleagues, like, hey, is this test that you want to get, is it a nice to have or a have to have? Is it talking with the OR front desk, hey, we need to make sure we have coverage going a little bit late in this room to make sure that we're getting them today instead of tomorrow. So communication up and down and sideways in order to help push forward the care for these patients is huge. But also understanding, the realities of everywhere we work, and knowing what we can control and can't control, working, make sure that the patient understands what we're trying to do and how we're trying to do it. That's great. All right, Nick, let's go ahead and finish it off. Last paper right here.
All right, sounds good. This is a paper in JPJS published in 2008. Early operation on patients with a hip fracture improved the ability to return to independent living. So we're going to drive home some points like we already have about timing, but then an important aspect on this paper is the return to independent living aspect, which we'll get into here in a second. So as we make clear, hip fractures, some of the most common orthopedic injuries, we see mortality rates as high as 30% at 1 year. And like that chart that Brie had shown on the last slide, that mortality rates continue to increase as time passes. 30-day mortality rate following surgery reported at 9%. There's some variability in that. And like we've been talking about for the last couple minutes, there's a little bit of controversy as timing hip fractures and when is the perfect time, and what are the variables in regards to when we fix them. So just setting the stage a little bit, this review paper by Kahn et al., 2009, he reviewed 52 studies, almost 300,000 patients. These studies produced a little bit of conflicting results regarding mortality and morbidity, whether being increased or unaffected by delaying surgery. None of the studies in his review article reported any adverse outcomes for early surgery, which is an important point. So we can never maybe be too early. In conclusion, so early surgery within 48 hours reduces hospital stay and may reduce complications. So this paper also is going to divide up a little bit different variables, 24, 36, 48 hours compared to people who have surgery at a later date. This is a 1-year prospective study, 850 patients, to level 2 study. So some of the outcomes that were measured included the ability to return to independent living, which is the real important point here with this study, risk for development of pressure ulcers, and length of hospital stay and mortality rate. So some of the results. So surgery after 36 and 48-hour groups after admission were less likely to return to independent living within 4 months. So that's really the point that this paper wants to drive home. The longer we wait, there's a increased chance that the person will not return to independent living at the 4-month mark. There's no significant difference with the use of the 24-hour limit. So we have a little chart at the bottom there that talks about this a little bit more, and that's just going to reinforce return to independent living. Decrease the longer that we wait. Looking at pressure ulcers, the incidence of pressure ulcers in the groups that had operation later was increased at all 3 cutoffs. So the longer we wait, more incidence of pressure ulcers. The odds ratio for the 24, 36, and 48-hour group was about 2 for the 24-hour group, about 3.5 for the 36-hour group, and 4.3 for the 48-hour group. The longer we wait, more chance of pressure ulcers. So length of hospitalization was also a variable this study looked at. It's increased in the groups that had the later operation. So the median was 14 days compared to 18 days for the 24-hour group, 15 days compared to 19 days for the 36-hour group, 15 days compared to 21 days with the 48-hour group and later, respectively. The importance of surgical timing remains significant even after adjusting for co-founders. So that is something that the authors of this paper evaluated. So the big takeaways here: early versus late fixation of hip fractures associated with improved ability to return to independent living, reduced risk for pressure ulcers, and a shortened hospital stay. You could say one of the challenges of this study is the length is 1 year. Maybe it could have been longer. Looked at these variables for a bit of a longer time. But that was the only thing I could identify that may have been a possible downside.
Yeah, for
Like
sure.
you've been saying, oh, go ahead.
No. Yeah, and like, right, there's always limitations as far as like it being the various. I mean, it's a level 2. It's not evidence based, or it's not a. Oh my gosh, I'm blanking on it. Oh my gosh. Randomized controlled study, like, which we can't do with these things, which is totally fine. My question for you, Nick, is so grandma's there with her family, and she's like, okay, you've talked with us, your whole team's on board, we're going to be working with a bunch of people, she's ready to work really hard with physical therapy and get moving as soon as she's done. You're going to take her to surgery and basically as soon as it's safe, and hopefully within 24 to 48 hours. So it sounds like as long as you guys get to her with 24 to 48 hours, like, she's going to be great. Is that right? She's going to be able to go back home?
Right. So we're going to say we hope that's the case, but we certainly can't guarantee it. The evidence that we've been talking about for this whole conversation we've had today would suggest that the earlier we do it, the better they're going to do. And if we sit on it for a week, that's certainly not going to do us any favors. But there's a chance that they don't return to independent living at all, and there's a chance that they do. The better the sooner we're able to, decide on surgery, get things prepped, get things medically optimized, get things squared away, that chance is hopefully better that they can go back to independent living. But it's certainly no guarantee. It's not a guarantee for anybody.
Yeah, for sure, right? And like, we're talking about odds ratios in this paper. We're talking about things like there's a better likelihood that they get back to independent living, but there certainly is still a risk that they don't get back to independent living, or they lose a degree of mobility and freedom after a hip fracture. And that's exactly right. Like, we're looking at all these things to help improve our chances, but there still is a risk. Like we talk about, even with operative treatment, there's a risk of mortality at 1 year. There's still a risk of mortality at 30 days. There's still a risk of loss of independence and a loss of mobility. And so I'll kind of, yeah. And so I'll kind of go here in conclusion. It's kind of from my experience, right? I'm still a third-year resident. I'm still learning, but from my time on consults and talking with my chiefs, my senior residents, my attendings, and looking at these papers, kind of develop a little bit of a spiel that we give patients when they come in talking about hip fractures. I kind of wanted to run through that with you guys, or just kind of to put it out there for you. I always talk about come in and I talk with a patient. You build the rapport, you talk with them, figure out what's going on, make sure that you figure out what their questions are, and then when you're getting ready to kind of explain what's going on, I always kind of go into, hey, whenever we're talking about hip fractures, it's not just the only thing that's going on. You usually have some different comorbidities, and the fact that you fell and the fact that you had a fracture can be a sign also of just kind of your overlying medical status, your overlying health. It can be an indication of fragility or the natural aging process, and can kind of be can kind of be looked at, or it can often be a sign of moving towards the end of life process. And how much I emphasize that kind of depends on their comorbidities and their overall, like, are they sick, not sick. I talk with them, we do know from our different papers and our different research, but this is a very common injury. We're able to get a lot of information. We know that taking a look at if there's a definite benefit to surgery and trying to get you back to activity. But even with that, we know that there is a certain risk, because once again, this is kind of a sign of your underlying medical status. And we say kind of up to a third of patients, even with surgery at 1 year, can actually there can be a mortality risk, or could die. Not typically from, or it's not coming from the hip fracture, but once again, all those different comorbidities and the complications of getting up and moving around. And I talk with them a little bit about the importance of motion and being upright and walking and activity in continued health and strength. And then so a really important thing is going to be, we can do the surgery and help you get you moving again, but a really important thing is going to be working with physical therapy and pushing through and getting active and getting mobile again. And so it's really going to be coming from you and your activity and your motivation to get moving again. So try to really motivate them from that point of view. And then I kind of go into a little bit of talking about, we talked about a third of folks will unfortunately pass away within a year, about. And once again, depending on your activity level and what you're able to do afterwards, those are the things you can control and work towards. But we do also see, a third of folks are able to get back to their normal baseline, moving around. A third of folks might have to, where they didn't have to use a cane, will have to start using a cane, or if they're using a cane, they might use a walker. If they're using a walker, they might start using a wheelchair, and that can have impacts on their ability to live alone, or versus needing help in an assisted living facility. And that's something that we'll continue to work with. Physical therapy, you might need a short stay in an assisted living or a physical therapy focused facility, with of course the goal of going home, but a lot of that's determined on your ability to get back to motion. And that's the best thing that we can do for you, is getting you back moving as soon as possible. And we're going to be working with your team to do that as soon as it's safe for you. And that's kind of the whole spiel. Well, guys, good job. Another one done, another one down. We talked about kind of the background of hip fractures. I'm looking forward to jumping in and doing a little bit more of the specific fracture care, to the more surgical side of things here coming up in the next couple episodes.